Well, good morning, everyone, and welcome to Edinburgh, and welcome to the first session of the SCTS Thoracic University. This morning, we're going to talk about multi-specialty thoracic surgery. What makes our practice safe when we perform operations? Well, it's having protocols, it's working in teams that work together and train together. It's learning from our experience and auditing our results, and therefore, through all of these things, getting into our comfort zone, which is maybe boring, but it's also really safe, and it allows us to do complicated things like put people off to sleep and put metal in their airway and wake them up again alive. Today we're going to spend the morning talking about what happens when those rules don't really apply, when you're doing stuff that you don't do every day, maybe no one does every day. It's not in the textbooks. And what we're hoping to do is to give some framework around making that kind of operation safe. What kind of operations are we talking about? Well, we're talking about airway surgery that you might do with your ENT colleagues, or mediastinal tumor surgery. We're talking about chest wall surgery for sarcoma or for advanced lung cancer. We're talking perhaps about esophageal surgery, which maybe 20 years ago our predecessors did on their own, but really across the country now we'll do with colleagues who specialize in that. And then increasingly we're talking about access surgery for spinal surgeons, again, who might have opened chests on their own historically, but now increasingly will ask for our help. This kind of operation means big teams, lots of people who don't see each other every day, who may not even know each other's first name. Why is a big team maybe a good thing? Well, it allows you to get expertise, to find the guy in the theatre down the road who deals with a problem that you deal with once every year, every week. Makes the uncommon common. I think it decreases the level of personal stress that you feel as an operator a lot, and it allows you, if the dynamics work, to share decision-making. It also allows you to optimize perioperative care, because again, someone might know what to do when you're not sure. How do we plan for those operations? Well, it probably starts months and years before, as you get to know people in your hospital or around your hospital who are going to be able to help you, who've got skills that might allow you to do a pancoast or take some vertebrae off, or who are involved in the sarcoma MDT, who know how to mobilize an LD flap. What else do you need to do? You need to sit down and think about whether something's common enough that you need a protocol in your hospital to do it. You need to think about whether you've got approval in your hospital to do it. And then you need to think about whether you've got the kit and the expertise and the nurses and the anaesthetists and the patient flow and the beds to allow you to do these sort of things. Moving beyond that stage, when you've got the individual patient, then it's important to get the workup right. We routinely investigate lung function and cardiopulmonary exercise testing, but your sarcoma surgeon, your plastic surgeon will do very different things to assess his LD flap. So you've got to get the workup correct. I think increasingly we have to think about consent and whether one person in a team can consent for the whole team, or whether patients should be meeting individuals, even briefly, for 5 minutes to talk about individual components if you don't know what a free tram flap involves. Some of these things, if there's enough volume, might justify a joint clinic. Everyone needs to have access to the documentation to know what each other are doing. And it may be useful to do a circulating email pre-WHO, where you talk through what you're going to do several days beforehand. So if there's obvious problems, you can work them out. This is our whiteboard from theatre doing a case that took us all day, down to point 13, a bad number. Clearly, these cases are where things like the WHO come into their own, and it's essential to orientate and introduce visiting teams. They won't know your nursing staff, and your nursing staff won't know them. To talk clearly through what you're going to do. It may be that this is a case where there'll be points in the operation where you're going to assess whether you're going to proceed at all, and people need to know what those points are, and whether there's areas where you might decide to bail out and do something less major. We're all used to being in charge. Clearly, when you're operating with another specialty, you won't be in charge of the whole thing. Sometimes that works really comfortably, especially if you know each other. You may need to think about whether there's a formal leader of the surgical team, or whether you're just going to organically do it between you. You need to liaise with your anaesthetic and intensive care team. And clearly, communication with the family is important as well. They can't be told different things by different people who've been involved. You also need to think about training. A big, long case isn't necessarily one where there's no training component. But clearly, if you're going to spend 40 minutes taking your registrar through something, everyone else has to be happy to sit and watch you. They may not always be happy. Where should those patients go afterwards? Well, it's for individuals to decide, but probably where the greatest dependency, where the most skill is needed. If you need to be assessing a flat viability afterwards, then maybe they should be on your plastic surgery ICU. If it's more about neurosurgical monitoring, then maybe they should be in neurosurgical ITU. And then you need to think about looking after that patient until they're discharged. Where I work in Bristol, a lot of our joint specialty surgery is done off-site, and so I need to plan my week to be able to drive up there and see the patient if I'm worried about them. You need to make your orders and plans clear, because people won't automatically know what you do because you do it every day. In fact, they may never have managed a chest drain before. Does everyone know who to phone? Should you put your phone number in the notes? Are you going to be directly called, or is the guy on call going to be called? People need to know that stuff, and you can't assume that they understand what's in your head. And then there's administrative challenges. A lot of this stuff isn't coded for outside NHS practice. Tariff is unclear for some of the surgery in NHS practice. And it's quite hard to hit cancer targets in a 31-day target if you've got 3 surgeons to get in a room on the same day. It's like herding cats. What else is difficult? Well, coordination, getting everyone there on time. I think you have to accept that sometimes you're going to hang around and sometimes you'll be called and spend the morning somewhere and actually you won't be needed. This is a chest wall sarcoma that you can actually see hadn't gone into the ribs. I spent a good chunk of one morning watching the plastic surgeons do that, but that's part of the game. So we're going to have some great speakers this morning, from chest wall surgeons to esophageal surgeons to neurosurgeons. I hope that the message that's going to come out of the day is that to ensure a good result, you don't just need outstanding individuals, fantastic location, and the right kit, but you need to work together with your colleagues and the right equipment to ensure the right outcome. So this is the program for this morning. I'm going to start off by inviting Richard Page to come and talk to us about esophageal and airway surgery. Richard.